All right, good afternoon, everybody. Welcome to our weekly Advanced Heart Failure and Transplant Cardiology lecture. Today, very happy to welcome Dr. Juan Ortega-Legaspi, who's joining us from the University of Pennsylvania. Dr. Ortega began his medical career in Mexico prior to coming to the United States for his internal medicine residency training at Emory. He then did his cardiovascular disease training at the University of Washington in Seattle, which is another one of our partners for this heart failure lecture series. And then finally ended up at the University of Pennsylvania, where he completed his Advanced Heart Failure and Transplant Cardiology Fellowship. So I'm very happy to welcome him today, and he's going to talk to us about cardiac allograft vasculopathy. Thank you so much.
Well, thank you very much, Dr. Beasley, and thank you for putting together this series. I think this is a great idea, great initiative. So I'm happy to be part of it. So let's get started. Let's just keep this. I like to keep these nice and casual. And if there are questions on the go, please feel free to interrupt or raise your hand. Otherwise, I'll just get to it, and we can have some time to discuss at the end. So all right. So I want to skip this because that we didn't do. So anyway, so just reviewing something that you guys already know. I'm just going to go over this very quickly for time purposes. But as you know, cardiac transplant survival, we have a median survival that it hovers around 13 years, and that's driven by a number of things, right? So of course you've got the first year that's significant for graft failure at the very first, the very first few days. Then you've got a lot of infection when people are more immunosuppressed. And then as a patient do well after the first year, you've got two of the lines here that are increasing. One is, malignancy. As we know, immunosuppression increases the risks of malignancies. And the other one, which is the one that we're about to talk today, is this red line, which is a cardiac allograft vasculopathy, which basically affects and accounts for up to somewhere around 10 to 20% of deaths in the chronic heart transplant population, and it does carry significant burden of morbidity and mortality. So that's what we're going to talk about. So what is it? So obviously it is coronary disease, but we need to understand that it has a very different pathophysiology as that of traditional coronary artery disease. You don't have the classic atherosclerotic plaque with intimal thickening, whereas you have hyperplasia of the intima. It is understood more as a chronic inflammatory process. You can even argue that it is a chronic form of rejection in which you have chronic inflammation inside the blood vessel that generates vascular disease and manifestations of coronary disease with different pathophysiology. Now, of course, since this is chronic and it doesn't happen in focal lesions, while you can have focal stenosis in the coronary vessels, it can also be very diffuse. And this is very important to keep in mind when it comes even for screening and what methods we're using, because it can be actually pretty even. You can have an evenly narrowed vessel in which you wouldn't necessarily be able to see focal lesions. For unknown reasons, some patients do develop focal lesions, but the lesions can be very, very widespread, very microvascular, very different than what you would traditionally see in coronary artery disease in the non-transplant population. So that's important to keep in mind. And another thing to keep in mind is that, of course, having a transplant doesn't exclude you from having the classic coronary disease. So you can have both. So that's another reason for which you can have focal lesions. The transplanted heart can still be subject to traditional coronary disease on top of this one. So it's not that one excludes the other one. You can have this fibromuscular hyperplasia that we're talking about, chronic inflammation with vasculitis, and of course you can have classic atherosclerosis like we were mentioning just in the previous slide. So the pathophysiology can be multifaceted, and it's important to keep that in mind when it comes to re-stratifying patients and also how to screen them and treating them, and and that explains some of the pharmacologic strategies and some of the treatment and prevention therapies that we have. So there are risk factors for these. Many of these, as you will see, include the traditional risk factors for coronary artery disease. So you have, hyperlipidemia, hyperglycemia, vascular disease, obesity, etc. So all of these are traditional risk factors for coronary disease, which should be included. And here, very importantly, these risk factors are both in the donor and in the recipient. So traditional risk factors for coronary disease are risk factor for CAV in the cases of both donor and recipient. And then, of course, you have the risk factors which are specific to this disease process that doesn't necessarily involve traditional coronary artery disease, which include the immune and the non-immune ones. So you have innate immune response, patients with history of rejection or positive anti-HLA antibodies or DSAs, and very importantly, CMV infection, which can be associated and understood as an immune or a non-immune process in which CMV can basically rev up the immune system and cause and be more likely to cause both rejection and CAV. And also the infection itself has been proven, at least in lab and in preclinical models, to have an effect for non-immune mechanisms. So CMVs are very important to keep in mind as a risk factor for the development of the disease. So anyway, so how do we traditionally diagnose and screen for it? Because as you all very well know, the transplanted heart being denervated doesn't necessarily exhibit any symptoms particularly early on. So this is a disease that most centers will start screening from between 6 months to a year post-transplant, and then continues screening for many years down the line. It's important to mention that the disease has been described as being present as early as just a few months post-transplant in some studies. So when it comes to screening, the gold standard is invasive with coronary angiography. Consider the gold standard, but it is somehow controversial, particularly if no ultrasound is used for the reasons we mentioned before, in which the disease can be that of the wall of the vessel, the intima, not necessarily express itself as focal stenosis. It has some risks, and this is the reason that many centers, and I'll be curious to hear perhaps from some of you what strategies different centers use in this forum. But of course, it's an invasive strategy. It requires a use contrast, and as we know, renal disease is very common in our patient population, and of course, it carries also a significant cost. Nevertheless, this continues to be the gold standard, and the way to grade disease is by angiographic findings. So the ISHLT basically grades it based on the angiographic findings, being 0 with no significant disease, and then you have some stenosis, which could be up to 70% in one vessel, then multi-vessel disease as 2, and then if you have left main coronary or several vessels, and also added to systolic dysfunction or even restricted physiology, then it can be considered severe. So it does include, especially at the very end, some functional assessments to call it severe. Now, these particular, this is something that I am sure it will change in the future, because, like we mentioned before, it's not perfect. It's not even done by a lot of centers routinely as a screening tool, and it has its own faults. One way of improving coronary angiography in order to better classify is by using the Stanford classification, which basically means adding intravascular ultrasound to evaluate the intima thickness and the extent of any potential plaques. And then based on the thickness of the intima and the extension of plaque, then it can be also classified that way. Now, intravascular ultrasound, some centers do it routinely, some don't. I can share with you that we don't do it routinely. In fact, we don't do angiography routinely at all for screening. We do it for if there is suspicion, but not for screening. And it has to do, basically, this adds another layer of risk. As you know, you have to cross a coronary, so it does add a layer of risk. And the cost skyrockets if you use intravascular ultrasound, which is why some centers will just not do it. And again, it's also not perfect. So having said that, there are a number of other screening modalities that can that can be used, particularly imaging modalities. Most of the data comes from nuclear medicine. And some imaging modalities are not as good. So, for instance, the first one that here is highlighted in red is dobutamine stress echocardiography, which basically is 60% sensitive. So it's pretty much, it's pretty much like flipping a coin. So not great. And many centers, ourselves included, have moved away from using this as a screening tool, given its very basically rather poor sensitivity. But you will still see this as a tool that's used, and it has some value, but unfortunately, it's not very sensitive. Then you've got traditional SPECT, which is also not the most sensitive that you can see here, but it can still be used, and many centers do use it. And then you have increased sensitivity and specificity with PET scans. So PET has over the last few years, particularly the last 2 or 3 years, has increased a lot. Is used as a screening tool for CAV in the transplant population, and that's not even considering the fact that it has other parameters that are under study, and there's some recent communications and some recent studies that have shown that things like coronary blood flow can be used as well for screening. So here are some of the advantages and disadvantages of some of these, and I'm happy to share this presentation with you. So in interest of time, we of course can't go over all of these in detail, but you'll see people using stress testing, but chronotropic incompetence is an issue. DSC, like we discussed, is not very sensitive. SPECT has also some sensitivity issues, and it has cumulative radiation. It's a longer procedure. PET is better than SPECT in many ways, but it's limitedly available. And then it does require further blood flow, particularly for myocardial blood flow and coronary myocardial blood flow and coronary flow reserve. There is more research going on for CTA and MRI. There will be more to come on that. It's not yet been validated completely, and it's not yet in use widely, but we will see more use of CTA and more research coming out of there. Having said that, this is a great area for research for those that are going to stay in transplant, as the imaging modalities and the screening and diagnostic modalities for this are evolving very quickly. So for those interested, it's definitely a good area of research. When it comes to treatment, well, some of the things that we do that it's basically done and has proven some benefit down basically for everyone is the use of statins. So basically, as you know, most transplant patients, if not all, should be on a statin unless there's a very good reason not to be on it. It's known that other than reducing cholesterol, which is what they were invented to do, they reduce cytotoxicity mediated by NK cells. They do have evidence of reducing allograft rejection and incidence of the disease, which is basically a preventative measure, which is why we use it. And they do reduce 1-year mortality. So most patients, again, unless there's an absolute contraindication for not statin, you should be on a statin. And then there's the treatment, especially in patients. And here, there's different trains of thought on how to do this. Should you put everyone post-transplant on mTOR inhibitors like some centers do, or should you do it when you have a suspicion for the disease? And that's an area of debate. It's an area of a healthy debate. In our center, we have a very low threshold to start an mTOR inhibitor if there is suspicion, but not all our patients are on mTOR inhibitors. And as you know, not every patient can be on an mTOR inhibitor. They are limited by renal function, proteinuria, and also remember that these medications impair healing. So if they're having procedures and all that, they have to be stopped, and they cannot be used if patients are getting surgical procedures. But it's a good, there is good evidence. The rejection evidence with mTOR inhibitors is mixed. In some of the clinical trials, they've shown improved reduction in rejection. In some others, not so much, or it's been negative or neutral. So that's why it continues to be a debate whether mTOR inhibitors should be used across the board in all patients, or they should be used when you have suspicion or some evidence, either imaging evidence or angiographic evidence of CAV. As I was mentioning before, the previous slide, they reduce the incidence of CAV, that they do. The data about rejection conflicting. And they do work better if done early. So that's why here part of the debate is like, well, should you just put everyone on them, or should you just do it when you have a early suspicion? As if you do it late, then none of these are silver linings. None of these cure the disease. None of these reverse CAV. Once you have it, you have it. So this is more currently the current treatment for CAV is preventative and trying to prevent, and if you have it, trying to prevent its progression. And unfortunately, we don't have a lot that really works in a way that satisfies any of us. In fact, I can steal a comment from one of our colleagues from Spain. Dr. Ferrero once referred to CAV as a HFpEF of transplant, meaning that, we don't have much that works. It is quite prevalent and it has a lot of morbidity and mortality. So it is a little bit of our Achilles heel when it comes to transplant in many ways. And then what if you have significant disease and you can go after it in a traditional way? Well, there is a role for revascularization for CAV, but not so simple. So like we mentioned before, the lesions can be very diffuse, can be very distal, can be very pruned. So a stent might simply not do it. If you have a focal lesions, by all means, go for it and unleash your interventional plumbing friends to open the coronary plumbing. But it's not always so simple. As you know, it can come with its own complications. And unfortunately, in these patients, there is a higher incidence compared to the non-transplant population in in-stent restenosis, death, and MI. So it can be done. It should be done if there is a target for it. But don't expect that is necessarily going to change things significantly. And there's also a role for CABG. I can tell you there are centers, it's extremely rare that a patient goes to CABG for CAV. It can be done. It's described. Some centers do it. It is in the literature, but the mortality is significant, and most surgeons will be very hesitant to do it unless it's quite a good case. So CABG is done. It's an option, but rarely used. And then ultimately, in the current era, if you have progressive CAV that does not respond to any sort of medical therapy, the patient develops heart failure or angina or both, and is symptomatic from it, then really the only treatment is consideration for retransplant. Now, retransplant, of course, is a very also a hot subject. There are ethical considerations. There will be, we can even set up a debate, and there can easily be a side of that debate that would say that a second transplant should not be offered. That knowing that the mortality and the survival from it is much worse than the first transplant. Of course, there's a question about resource utilization, etc. So some will be very adamant that a second transplant shouldn't be considered on anyone. I personally don't think that way, but you will see that, and I understand why that is part of the debate. Of course, the patient for a second transplant must be very, very carefully selected in order to justify using that resource. It is well known as a second transplant is now a thing that is done in many high volume centers around the world, but it is known that the mortality is higher. And very importantly, and again, part of this debate, is that the survival after a second transplant is probably comparable to medical treatment of this. Again, here is when the individual patient selection and the individual clinical characteristics are key in making a decision. But if you pull everything together more in a data analysis fashion, then the difference in mortality is not that great. But it is an option. It is done. Here at Penn, we have some experience. We probably would transplant maybe one patient a year, maybe in that ballpark for this. So it's something that is done. But it's definitely something controversial. And of course, as you might expect, many patients are not candidates for a retransplant for a number of reasons. Age, of course, being the obvious one. But there are other clinical and or social comorbidities that may impact the eligibility for a patient for a second transplant. So, summarizing, there is an algorithm of how to manage CAV in all the transplant populations. So you have heart transplant recipient, everyone goes on a statin, everyone goes on aspirin, and then if you have clinical suspicion for it, then you go and try to diagnose invasively. If you only have risk factors, then you can do screening, and you continue annual surveillance. If you have evidence of the disease, you strongly consider mTOR inhibitors If there is a flow limiting focal lesion, then you can consider vascularization, and after that, continue annual surveillance. And if patient continues to progress clinically and do worse and develops heart failure or angina, then you need to ask yourself, is this patient a candidate for transplantation? And if the patient is, then go that way. And the patient is not, then unfortunately, the only current treatment is palliative care. So I do hope that some of you brilliant fellows will probably come up with a treatment for this that might hopefully incorporate something else into this algorithm, because right now it's actually quite grim in patients that do progress. It is frustrating not necessarily being able to help a lot of these patients in this population. So, to conclude, it's important to keep in mind that this is a condition that is chronic, progressive, has significant mortality and morbidity. Diagnosis and screening is not moving forward. A lot coming. That's basically most of the research about CAV that's coming out right now is about screening. I honestly wish there was more about treatment, but I think there will be. There is some exciting preclinical data on viral vectors, etc. Things that might potentially change it, but nothing that's out in the pipeline for clinical practice anytime soon. And of course, if the disease is rapidly progressive, it carries a worse prognosis. And again, the disease modifying treatment is quite limited. So there will be more to come on this. So that's basically all I've got. I think I'm trying to stick to the time that we agreed to, and I'll be more than happy to have a discussion if people are interested.
Yeah, thank you so much, Dr. Ortega. That was a fantastic overview of the disease process. Does anybody in the group who's logged on have any questions? You can either raise your hand, unmute yourself, or put a question into the comments. So a question here from Dr. Pinto. Any experience using PCSK9 inhibitors post-transplant?
Yeah, that's a good question. I think I mean, as far as general, I am not aware of anything, and I might be missing some updates here, but I am not aware that PCSK9 inhibitors have been formally studied. Someone here correct me if I'm wrong, but as far as I know, not particularly. And I think it's definitely an area worth exploring.
A question I have for you is just to compare our practices at different sites. What is your guys' go-to for statin and dosing in regards for CAV prophylaxis?
Most patients start, kind of defaulting the old, the old data from pravastatin.
Mm-hmm.
So that's what most people get started, but especially the ischemic ones, they very often we just go to the usual high potency with atorva and Rasuva.
High intensity, yeah. Yeah, we previously were using rosuvastatin, and then last couple of years here we've transitioned to using pravastatin as our primary choice. Another question
and
in the
it's
chat.
mostly because that's the one that was studied, and that's the one that showed the benefit. But
Yeah.
that study is actually pretty old. I think there should be an update on the statin part.
Yeah, and I think maybe jumping back to the previous question too, maybe the statin benefit in CAV prophylaxis has some of that due to some of the pleiotropic effects where you're not going to necessarily get that same benefit from a PCSK9 inhibitor, just, according to how it works.
Right.
I'm not quite sure, but I'm just postulating about that. Another question in the chat here is, so he put in published by Michelle Hamilton years ago. Dr. Pinto knows a lot though, so
it's alt, yeah.
Yeah. So patients who have cardiac allograft vasculopathy from CMV infection, can this be reversed or modified with the treatment of the CMV?
So you can, and you should absolutely treat it. I mean, no matter what, if you have CMV, it's known that the risk increases, and recurrent CMV makes it worse. So it's hard to study because anyone that has the CMV gets treated, right? It's not that you let them cruise with CMV. So we know that it increases the treatment. And to answer a specific question, how much does it decrease when the CMV goes away? That's hard to tell. But you absolutely should do it. But generally, it's understood that once you have CMV, it is considered a risk factor. Now, it's not one of those, it's not an on-off kind of switch that you have CMV, then you sort of sudden you have people with CMV without CMV and all that. It's
Mm.
just a risk factor, and the specific effect of the success of treatment is really hard to tell. And again, you wouldn't let anyone with CMV just cruise along. You have to treat it.
Right,
So
right.
it's not that you can randomize treating CMV versus not treating CMV.
Absolutely. Yeah, absolutely. What just to get your thoughts, I know you said there's some data maybe coming down the line in regards to additional imaging modalities. What do you feel about CT angiography of the coronaries as a potential screening mechanism? Since we do still get that anatomical information from CTA of the coronaries that we don't necessarily get from myocardial perfusion imaging. Do you think
I,
that
I
might?
think it just need, I think it just needs further study, because the problem is that the studies from CT that have come out haven't really shown that it's that good. But I think it needs further tweaking, because I mean, CT ultimately can see the wall, but it can mostly see calcium. So in these particular
Mm,
cases, there necessarily isn't any calcium in the wall.
right.
And you can have increased wall thickness without calcium and with a normal lumen and still have the disease. So that's where it's going to be tricky, and I think that the people in imaging may have to tweak how they do it. I think there'll be more to come. I'm honestly probably more excited about what's going to come, more on PET and more on MRI. I think that's probably going to be more useful for this specific disease process. But who knows? There's definitely a lot coming out. There was even a recent, most of what's coming out right now is probably coming from PET.
Mm,
About the validation and the use of myocardial blood flow and coronary flow reserve. And there's a recent paper, I forgot to publish. It was a recent paper that came out in the last 6 months about that. Um, and here at Penn, we're working on some of that. We haven't quite published a paper, but we presented this data at the ISHLT last year. So that's where most coming out. CT still needs to evolve a little bit more. So does MRI, and I'm personally a little bit more optimistic that MRI will be more of use when it comes to this. And of course, MRI has other uses in transplant, which includes the ability to assess for inflammation and rejection
yeah,
and things like that,
yeah,
which is also very useful.
yeah. Well, are there any other questions from the audience? Well, if not, Dr. Ortega, thank you so much again for taking the time today. Really appreciate you sharing your wealth of information about cardiac allograft vasculopathy with us. And we'll be back next week. And next week's lecture will be on endomyocardial biopsy. Thanks, everybody.
Thank you.